Welcome back to part 2 of the case report structure. In the last presentation, we left off with the case report assessment. The next step after that is to go into the intervention. So what you want to do is describe all the interventions that you've done. Describe the frequency of care, how many times per week you saw the patient, the duration, for how long, how many months, when did you do reevaluation and reassessment. You want to be specific about describing this intervention. You want to describe it in sufficient details to allow someone else to reproduce your care. So you may want to talk about how you approach the patient, how you determine the phases, the dominant phase, the dominant occiput, how you approach the spinal gateways for maximum efficiency. Really be as detailed as you can. Of course, you don't want to describe what you did every session, but you should at least describe how you approach the patient, what you did to them at least once, so that someone else can interpret what you did and could reproduce it. One of the things that you really want to do is to re-talk about your reevaluation and the changes that have been made. We'll talk a little bit about that later. In the results part of the case report, you want to describe all the changes in the outcomes that you've measured. So basically, if your outcome measure were looking at muscle tone, passive system tone, control system tone, heel tension, eversion stress, AD abduction, you want to describe on how those changed over time. This is very important. The same if you use some more outcome measures such as SEMG, thermography, postural pictures, or other type of technology that you use to have a more objective outcome. You want to describe how those evolved over time. One of the things you also want to do is describe any apparent side effects of reaction that the patient experienced or challenges to your care. One thing you also want to describe is distinguish between the short and the long-term outcomes. So for example, in the first part of your care, you may have had some short-term outcomes with the patient to reduce their symptomatology versus having long-term outcomes as far as their overall health or well-being. As well, some of the things may have changed pretty quickly. So muscle tone, control system tone may have reduced quite rapidly in the short term, but then you realize that it took long term for the patient's overall health to start coming back. So you want to distinguish between those. One other thing you also want to do is describe what's called the threat to the conclusion that change occurred. So let's say, for example, that you started by palpating muscle tone. We know that palpation has quite a moderate intra-examiner reliability. That means if you do it yourself once and do it again, you can pretty much find the same thing, but it's pretty poor inter-examiner reliability, meaning it's very subjective. So if you say, I palpated the patient's muscle tone and after 2 months of care it decreased, you have to describe the fact that it may not have actually decreased, it's just your perception of it. So you have to talk about the fact that your outcome was very subjective and an objective one. This is why using objective measures such as SEMG or thermography or ranges of motion or postural changes or heart rate variability is great, because we reduce the threat to the conclusion that a change occurred. Once you're done, you go to the discussion and you want to describe the conclusion and interpretation of the results of care and the suspected causes. So for example, if after 2 or 3 months of care the patient who had migraine is no longer suffering from migraines, you want to try to create an hypothesis as to why that occurred. You may want to talk about how by reducing adverse mechanical cord tension we reduce some of the tension on the rectus capitis posterior minor, and that reduced the tension that was created on the fibrous band that attached from it to the dura mater. Try to explain how your patient got better as far as the physiological mechanisms. Then you also want to describe the threat to the conclusion that the intervention was responsible for the changes that you saw. So let's say, for example, you were taking care of a patient with depression, and after 2 or 3 months of care, the patient is feeling better. Well, you have to ask the question, is it due to me? Because maybe the patient started taking antidepressant drugs at the same time he started with you. In that case, well, the changes may not be due to what you did. It's pretty obvious in that case, but for example, sometimes it's more difficult to know what did the change. Maybe you started taking care of that person, and at the same time he found out a new partner who really uplifted his mood, and maybe the change in depression has nothing to do with you. So you have to talk about the limitation of your care. One other thing you also want to discuss is the limitation of the generalizability of findings. And this is very important because this is probably the biggest mistake made by first-time authors. Most of the first-time authors are so excited about the changes they're reporting on that they tend to overgeneralize. So for example, someone took care of a kid with ADHD, and after 2 or 3 months of care, chiropractic tremendously helped that kid, and they go on talking about chiropractic is the best treatment ever on the face of the earth for ADHD. Don't do that, please. Stick to what you observed. Don't overgeneralize. Like for example, if you've taken care of a male that responded well, it may not be true that doing the same with a female would give the same outcomes. So just stick to what you've described. What you want to do then is to suggest direction for further investigation. Maybe something that you did wasn't great and you think you should have done it differently in the way you took care of the patient. Or you may want to suggest that, with the kind of result we have, it would be really worthy to do a before-after study or even a prospective control study. After that, you want to conclude. So the conclusion is basically a concise discussion of what you concluded as a result of your review of the literature and your experience in this case, as well as the significance of the case. Basically, just quickly summarizes your whole case report. If you have figures and tables, put one table or figure on a single page, so each figure should have its own page. Each must have its own caption or legend and should be comprehensible without reference to the text. And the last one is references. You want to start references on a new page, at the top of a new page. You want to list all the references that you use in your case study to support your case and the statements that you've made in there. You also want to select the preferred reference style. That means each journal has a specific style of reference they want. I have included all that information in step 4 for you. If you need additional resources, they're included right below this presentation. The first one is this PowerPoint presentation. You can download it to review at any time you want. There's also an essay case report tutorial. This is a Word document that summarizes what we talk about today. And then there's 3 examples of published case study. The first one is a short case, about 4 to 5 pages. The second one is a long case, 15 pages. This is actually my case study on quality of life improvement. And then I've added a third case. This is a case report that describes 2 patients into one report. So if you want to describe more than 1 patient, this will give you the structure. As always, if you need any help or assistance, you send me an email or call me. I look forward to see you to the next step.